Hello, we are discussing today the topic about the anatomy of Eustachian tube. Eustachian tube is a dynamic channel that are linking the middle ear with the nasopharynx, and it is also called as a pharyngotympanic tube or auditory tube. We are discussing this point in Eustachian tube anatomy, embryology of Eustachian tube, parts of Eustachian tube, and muscle of Eustachian tube, the difference between the pediatric and adult Eustachian tube, physiology of Eustachian tubes, Eustachian tube function test, and Eustachian tube dysfunction or disorder. This is a horizontal section through the Eustachian tube. Here we can see the tympanic membrane, 3 ossicles. This is the total length of the Eustachian tube, which are the 36 mm length. This is a bony portion of Eustachian tube situated posterolaterally, and this is a fibrocartilage part of Eustachian tube situated anteromedially. Here we can see the tympanic opening and pharyngeal opening. Tympanic opening situated in the bony portion and pharyngeal opening situated in the fibrocartilage portion. This is a tubal cartilage, and here we can see the mucosa. We will discuss the brief in Eustachian tube parts. Now we are discussing about the embryology of Eustachian tube. The Eustachian tube is developed from the tubotympanic recess. The tubotympanic recess is derived from the dorsal part of the first and second pharyngeal pouches. Here we can see the development of the Eustachian tube, auditory tube or pharyngotympanic tube from the tubotympanic recess. The muscle and cartilage which develop from the surrounding mesoderm. Now we are seeing this picture that there is a lateral wall of nose. We can see there is a superior turbinate, middle turbinate and inferior turbinate. The Eustachian tube that's seen in the posterolateral wall of the nasopharynx. When we are doing the nasal endoscopic evaluation at the level of inferior turbinate, but Eustachian tube opening is seen 1.25 cm behind the posterior end of the inferior turbinate. That the Eustachian tube connect the nasopharynx with the anterior wall of the middle ear. Here the same diagram that we can see the cartilage part and bony part of the Eustachian tube that connect the nasopharynx with middle ear, and here we can see the pharyngeal opening of the Eustachian tube during the nasal endoscopic evaluation. Now we are seeing the epithelial lining. The epithelial lining of the Eustachian tube respiratory mucosa is pseudostratified ciliated epithelium. There is a presence of goblet cell and mucosal gland, and the cilia beat in direction toward the nasopharynx. So what is the main function? That cilia drain the secretion and fluid from middle ear into the nasopharynx. Now there is a goblet cell and mucous gland which are decreased in number at medial to the lateral side. Now we are discussing about the part of Eustachian tube. Eustachian tube is two parts, bony portion which are situated at posterolateral part and fibrocartilage portion which are situated in the anteromedial part. Now total length of the Eustachian tube is 36 mm length, but now the bony portion of Eustachian tube is a 12 mm in length situated posterolateral part, and it makes 1/3 of the total length. There is a widest orifice in the anterior wall of the middle ear. It's a tympanic opening and is situated just little above the middle ear floor, and its diameter is 5/2 mm. There is a bony portion of Eustachian tube is situated in the petrous and squamous part of the temporal bone, and roof of the bony portion of Eustachian tube there is a thin bony plate of the tegmen tympani, and medially there is a carotid canal, and here the isthmus is narrowest portion of Eustachian tube, 0.5 mm in long. Now we are discussing the fibrocartilage portion of Eustachian tube, which is a 24 mm in long. This is situated anteromedially, and it makes total 2/3 of the length of the Eustachian tube. Now we are discussing the cartilage part. The cartilage part, it is an inverted J shape. There is a long medial lamina, there is a short lateral lamina. Between two lamina there is an elastic hinge of rope. This is a fibrous membrane. This is an Osman pad of fat and two muscles which are attached to the both lamina. At the medial lamina, there is an attachment of the levator velar palatini. At the lateral lamina, attachment of the tensor velar palatini. This is a Eustachian tube at the rest position. But when there is a contraction of the muscle, both muscle, tensor velar palatal, levator velar palatini muscle, there is an opening of the cartilage portion of the Eustachian tube. There is a medial end, there is an opening that forms the torus tubaris. And behind the torus tubaris, there is a pharyngeal recess and fossa of Rosenmuller. As we have discussed about the tympanic opening, pharyngeal opening, torus tubaris and fossa of Rosenmuller. Now we are discussing the point about the muscles of Eustachian tube. Muscles are tensor tympani muscle, levator velar palatini muscle, then tensor velar palatini muscle, then pharyngeal muscle and salpingopharynx muscle. That's tensor velar palatini muscle. The tensor velar palatini muscle is originated from the bony wall of the sphenoid, runs over the short arm of the lamina, which tendon turn medially around the pterygoid humulus and fibrous that diffuse in soft palate and meet to the opposite side of fiber. As we have discussed that the main function of both muscles are the opening of the Eustachian tube and this supplied by the mandibular nerve. Another muscle are levator velar palatini, pharyngeal plexus, salpingopharynx. This is a vertical section of Eustachian tube with both lamina. When this is a first figure to show that the Eustachian tube is closed in resting position. But the second figure shows that the tube is open when the tensor velar palatini muscle is contract. So this is called as a dilator of the tube. Now we are discussing about the difference between the infant Eustachian tube and adult Eustachian tube. Infant Eustachian tube, it is a 13 to 18 mm at birth and adult Eustachian tube is a 36 mm long. Infant Eustachian tube, there is a no angulation, but at the adult Eustachian tube, angulation at 45 degree at the horizontal planed level of isthmus. Infant Eustachian tube, as we are saying that it is a more horizontal in direction, but it is not horizontal, it forms the angulation. So in infant there are high chances of the infection that spread from the nasopharynx into middle ear via Eustachian tube because of Eustachian tube is more horizontal and no angulation. So high chances of infection that spread towards the nasopharynx into the middle ear. Now Eustachian tube in infant is a flaccid, but there is a comparatively rigid Eustachian tube in the adult. There is a Osman pad of fat and elastin hinge is less dense and less volume in the infant, but in adult there is a high dense and high volume. So elastin hinge of roof and Osman pad of fat has a main function to close the Eustachian tube, so that can prevent the nasopharyngeal secretion and nasopharyngeal reflux. Now the blood supply. The blood supply of the Eustachian tube are ascending pharyngeal artery and middle pharyngeal artery, venous drainage by the pharyngeal plexus, lymphatic drainage by the retropharyngeal lymph. Nerve supply, because they have four muscles and now each muscle has a different nerve supply. The tympanic branch of cranial nerve, ninth nerve, they carry the sensory and parasympathetic secretomotor fiber to the tubal mucosa. There is a cranial fifth or trigeminal nerve, third part, they supply the tensor velar palatini and tensor tympani muscle, and cranial part of ninth nerve through vagus nerve that supply the levator velar palatini and salpingopharyngeus muscle. Now we are discussing about the physiology. Normally, as we have discussed, Eustachian tube has two parts, bony part and fibrocartilaginous part. Bony part is always open, but cartilaginous part is closed at rest but open on swallowing, yawning, sneezing and forced fluid infection. Now we have discussed before that Eustachian tube cartilaginous part is opened by active contraction of the tensor velar palatini and passive contraction by levator velar palatini and closed by elastin hinge of roof and Osman pad of fat. The function of Eustachian tube: ventilation and regulation of middle ear pressure, protection against the nasopharyngeal sound pressure and reflux of nasopharyngeal secretion, and clearance of middle ear secretion. The examination of the eustachian tube. As we know, the eustachian tube has a two opening, tympanic opening and pharyngeal opening. Tympanic end of eustachian tube is examined by microscope, endoscope and by through otoscope, and pharyngeal end is examined by posterior rhinoscopy, rigid nasal endoscopy and flexible nasopharyngoscopy. Now we are discussing about the eustachian tube function test. So we are building the manure building the positive pressure in the nasopharynx, manure building the negative pressure in the nasopharynx, and some mucociliary and drainage test. Manure building the positive pressure in the nasopharynx, that are tests are Valsalva test, Politzer test and catheterization test. Manure building the negative pressure in nasopharynx, the tests are the Toynbee test. Another test is mucociliary drainage and secretion. The tests include saccharin or methylene blue dye test, and we can use the antibiotic or steroid ear drop. Another is a tympanometry or impedance audiometry test and sonotubometry test. These all tests are described in brief in later slide. Now we are discussing first the manual building the positive pressure in the nasopharynx. What is this principle? That principle is the positive pressure in the nasopharynx that cause air to enter into the eustachian tube. This method can be employed therapeutically to ventilate the middle ear. So how can we do this test method? First, air is pushed into the middle ear and tympanic membrane moves upward. So which can be examined by otoscopy and microscopy. In case tympanic membrane perforation, there is a hissing sound heard. If there is a middle ear discharge, there is a crackling sound heard, and this sound heard by the use of stethoscope. But an auscultation tube can connect with the patient ear under the test ear of examiner. Now Valsalva test. Valsalva test method is first ask patient to pinch his nose, then patient take deep breath through the mouth and then close his mouth and try to blow his cheek so that pushes the air into the ear. But this test has contraindication if there is an infection of the nose and nasopharynx or there is an atrophic scar or the tympanic membrane, because healed or any scar of tympanic membrane, it will lead to the rupture of tympanic membrane. So we cannot do this test in this condition, and only 65% of person can do this test. Now second is a Politzer test. Politzer test, it is done in the children because they cannot perform the Valsalva test. Now in this test we are manually building the positive pressure in the nasopharynx. First, olive shape of tip bag that introduce into the one side of the nostril, that the patient in the eustachian tube patency should be tested. Other side of the nostril will be closed, and then Politzer bag compress and ask a child to swallow the sip of water or say ick ick. So if eustachian tube patent, the hissing sound can be heard. This is for the manual building in the positive pressure in nasopharynx. Test is also used for therapeutically to ventilate the middle ear. Now the eustachian tube catheterization test is same, the positive pressure in the nasopharynx. Now the eustachian tube catheterization test, before this procedure, nose is anesthetized. Eustachian tube catheter that pass in the floor of the nose, then it's rotated to the 90-degree medially to the end of the septum. Then it rotates the 180-degree laterally, so the tip of this catheter that lies against the pharyngeal opening of eustachian tube, and Politzer bag that connected and air is insufflated. So entry of air to middle ear is verified by this test. There is a lateral bulging of tympanic membrane can see through the otoscopy examination. Now the complication of this test, that patient can be chances of injury to the eustachian tube. There is a bleeding from tympanic membrane. There is a vasovagal syncope attack, or there is a injury of eustachian tube, another surrounding structure. And this test is contraindicated, or this test is difficulty in this deviated nasal septum or adenoid hypertrophy patient. Now we are discussing about the tympanometry or inflation deflation test. Tympanometry test when there is a positive and negative pressure that are created in the external ear and ask patient to swallow repeatedly. In this test is done in there is a patient with perforated or intact tympanic membrane. There is a radiological test also done that said that there is a mucociliary drainage and secretion test are saccharin or methylene blue dye test or ear drop that into the tympanic membrane perforation. Discuss about the tympanometry test. The principle of the impedance audiometry or tympanometry that ABC. A is for the oscillator that produce the tone, the 220 Hz. Then B, there is an air pump to increase or decrease the ear canal pressure. And C, this is a microphone that pick up and measure the sound pressure level that is reflected from the tympanic membrane. Now the radiological test. In radiological test, instill a radio opaque dye into the middle ear, take X-ray and observe the Eustachian tube or check out the Eustachian tube obstruction. Now there is a test for the mucociliary drainage and clearance. These tests are conducted in case of tympanic membrane perforation. In this test, the time is taken by the material to reach into the pharynx and impart its test provided the idea about the functioning of Eustachian tube, measure the clearance of tube. So this material should be used like saccharin or methylene blue dye and antibiotic or steroid ear drop. First that we are doing the saccharin solution. Saccharin solution, the drop is instilled in the ear. The time that taken to reach into the pharynx, that measure the time taken. Patient have test like sweet test that the Eustachian tube pattern or not we are checking. Then another is a methylene blue dye that methylene blue dye installed into the ear. Then time taken by the dye stain the pharyngeal secretion or pharyngeal wall that the time should be measured. Another is a use of antibiotic or steroid ear drop. These are installed into the ear and time taken by drops impart its bad test. There is a Eustachian tube patency should be checked. Now we are doing the disorder of Eustachian tube. There is obstruction of the Eustachian tube. There is a main two causes: mechanical obstruction or functional obstruction. Mechanical obstruction is due to the any anatomical abnormality or there is any infection. There is an intrinsic cause. There is upper respiratory tract infection, allergy, sinusitis, and barotrauma. Extrinsic cause are adenoid hypertrophy, nasopharyngeal tumor or mass, deviated nasal septum, and nasal polyps. And functional obstruction is occurred due to there is increased cartilage compliance, there is a poor resistance and poor function of the tensor veli palatini muscle tone. So these are the occur in the Down syndrome and cleft palate or submucosal cleft palate. Now we are discussing the brief about it. First, if there is a acute tubal obstruction, there is a absorption of the middle ear gases. So the negative middle ear pressure is created. So there is a retraction of the tympanic membrane and prolonged tubal blockage and dysfunction. Then the chances of the otitis media with effusion, atelectatic ear, or chances of perforation in the tympanic membrane. Or sometimes there is a retraction pocket or cholesteatoma formation. Here we can see there is a equal air pressure are generated in the external ear and the nasopharynx, or there is a Eustachian tube. The equal pressure and drum of the tympanic membrane is normal. Now we are saying there is a blockage of Eustachian tube. So blockage, there is a creating the negative middle ear pressure, drum bulging the inward that create the negative middle ear pressure, and that will lead to the retraction pocket, cholesteatoma formation, otitis media with infusion. This is main if there is any tubal blockage. The symptom of tubal obstruction like otalgia, hearing loss, mainly the conductive hearing loss. The patient have complaint of the popping sensation or tinnitus or sometimes disturbance in equilibrium or vertigo. Now sign as we have discussed in mechanism, there is a retracted tympanic membrane due to the negative middle ear pressure. There is a congestion along the handle of malleus or pars tensa, or there is a otitis media with effusion or transuded behind the tympanic membrane or amber color or the fluid level that will lead to the conductive hearing loss. In severe cases, we have found some patients that tympanic membrane markedly retracted or sometimes in the tympanic membrane layer there is hemorrhage, hemotympanum or perforation occur. Now, some functional causes are enlarged adenoid. Enlarged adenoid is caused due to the tubal dysfunction. Tubal dysfunction because if there is an enlargement of the adenoid, so the enlargement adenoid there is a pathogenic organism or reservoir in that. The inflammatory mediator in allergy that cause the tubal blockage. And adenoid can also cause the otitis media with effusion or recurrent otitis media. We have treated like adenectomy in this patient. Now, some are the cleft palate. Cleft palate is tubal function due to the abnormality in the teres tubaris and tensor villi palatini that doesn't insert into the torus tubaris. Sometimes in this patient also the otitis media with effusion is very common. Down syndrome. Down syndrome is occurred due to the poor tone of the tensor villi palatini muscle and abnormal shape of nasopharynx. Children have more prone to develop the otitis media or otitis media with effusion. Barotrauma it is non-suppurative condition. There is a failure of Eustachian tube to maintain the middle ear pressure at the ambient external pressure. The clinical feature of the barotrauma is severe hearing loss, mainly the conductive type. Sometimes patients have tinnitus. The tympanic membrane on examination, tympanic membrane retracted and congested, and middle ear air bubble or hemorrhagic effusion seen. This is the two condition when Eustachian tube in normal state and Eustachian tube is blocked. The barotrauma mainly cause that rapid descent during flight, underwater diving and compress in the pressure chamber. Normal flight and aircraft climb or descent subject with normal sinus condition, the tympanic membrane, middle ear cavity and the nasopharynx and Eustachian tube condition, the both side positive negative equal pressure, this is a normal state. But if aircraft is descent, the subject if there is any allergic or sinus condition, so there is a blockage of Eustachian tube and tympanic membrane displays inward, then high chances of the developing the otitis media with effusion if there is a inner ear symptom like vertigo and tinnitus. The main treatment to that aim to restore the middle ear aeration. In mild cases, we are providing or we are giving the treatment like decongestion or antihistaminic. In a presence of fluid behind the middle ear, we are doing the myringotomy operation. What are the prevention measures? That avoid travel with any infection or upper respiratory tract infection. Swallow rapidly during the descent of aircraft. Avoid sleep during the descent in aircraft. Auto-inflation of the tube by Valsalva during descent. And medication. So they have to keep medication like vasoconstrictor, nasal spray and systemic decongestant. There is a chances of recurrent barotrauma because patient have some condition like nasal polyps, deviated nasal septum, nasal allergy or chronic sinus infection. Patulous Eustachian tube. Then in this tube is abnormally patterned. The main cause of patulous Eustachian tube are idiopathic, but sometimes there is a rapid weight loss can cause patulous Eustachian tube. In third trimester of the pregnancy, mostly female patient has seen, and in multiple sclerosis. Sign and symptom of patulous Eustachian tube are the autophony, that on examination, movement of tympanic membrane with inspiration and expiration, and further if there is a patulous Eustachian tube condition exaggerated, patient breathe after closing opposite nostril. Retraction pocket, as we have seen, they create the negative middle ear pressure due to the obstruction of the Eustachian tube. There is a total atelectic of tympanic membrane. Sometimes there is obstruction of the middle ear, obstruction of the isthmus, or obstruction at the adductus. If there is an obstruction in adductus, there will lead to the chances of cholesteatoma granule, collection of the mucous discharge in mastoid hair cell, middle ear normal and attic normal. Now we are discussing the MCQ. Then we will further discuss or answer give in the next lecture. Thank you.